Evening, everyone. Today, I thought of discussing with you one of the cases that I have come across during my training at NHSL ETU. So, so we will start now. This is a case, I have called it masquerading case of limb weakness. On the outset, I would like to share that I would like to do this in an interactive manner as much as possible. We'll sort of start with the OSCE, and I would appreciate if someone could sort of volunteer, either individually or even as a group, you may be able to do the case. Okay, moving on. Can you see my screen?
Yeah, we can see.
Okay. So the case is a 75-year-old male comes to you with the following complaint. So task will be proceed with the history examination. Uh, the examination findings will be provided on request, but management is not required. We will be discussing on that. So for we'll try to do it in 5 minutes. Sorry, 8 minutes. Anyone who wants to, I will act as the patient. So either individually or as a group, you can ask me to do the OSCE and ask questions. I will answer.
Dr. Helika, is there a history of fall or any sort of accident?
Well, no, I did not have a fall. No, nothing like that.
Helika, what about his upper limb?
Yeah, yeah. Yes, doctor, because now, my upper limbs are okay now, but about 1 week ago, I had a sort of weakness in my left arm as well. That's 1 week ago. My left arm and left leg was also weak. And, my son told me that I was talking funny, but that only lasted for a few hours. Then I was completely okay. Then today only I got this problem. My foot doesn't seem to be moving the way I want it to. It's not keeping in the place where I intend to keep it.
Okay. Helika, do you have any visual problems in the past?
No, no, doctor. I don't have anything like that.
Okay.
Is this your first episode or was there a similar incident in the past?
Yes, doctor. The one I told you about, that's last 1 week ago. I told you for a few hours I had this left arm and leg sort of weakness, but it went away. Then this is the second one, but this time I have the problem is only in my left leg.
Okay. Do you have any numbness in your body?
Yes, doctor. I'm a diabetic patient. That now that you ask me, I have severe diabetes, and both my feet are numb. Actually, I can't feel anything below my ankles. So it has been there for some time. Maybe I could say it got a bit worse today, maybe, but it had been there for some time.
Okay.
Was there any specific incident that you can recall prior to the first episode?
Uh, in the sense, similar kind of.
No, not a similar kind. Something which caused you mentally, like mental agony or something. You were.
No, doctor, no. I okay. I'm a retired government servant, and I'm doing well. I'm doing well actually. I didn't have any problem like that.
Do you have any back pain?
Yes, doctor. I was going to tell you. I have this back pain, very lower down, somewhere over my buttocks. It's been there for some time though. Not for about maybe 3-4 weeks now. It's been coming on and off.
Okay. Do you have any urinary or any defecating problems?
No, doctor. No, I don't have anything like that.
Okay. This is some private question. Is that okay? If I ask you now,
Sure, sure.
what about your erection?
Yes, doctor. Well, you are correct. I have some problem there as well. No, it's not normally happening as it used to. Yeah.
How long it was there?
That again, I think maybe 4 6 weeks.
Okay, recent onset.
Yes, correct.
Did you take any treatment for that?
No, doctor. Considering my age, I didn't actually go behind it, but I didn't have to get it checked actually. Yes.
Okay. Can you give us your examination finding neurology?
Yes. Okay. So examination. You want the neurological findings?
Yes.
Okay. So cranial nerve examination normal. Upper limb examination neurologically normal. Lower limb neurology. There is the tone is normal in both. There is paresthesia up to the level of ankle in bilateral ankle joint in the bilateral volumes. Reflexes are normal. There's slight pain when moving the limb, and the apart from that, the joint, the power of the all major joints of the left side is little less than the right. It's about 2 out of 5. Right side is 5 out of 5.
Okay.
Anything else that you want to know, Dr. Taman?
Uh,
Have you had any chest pain previously?
No, actually, no. I have not had anything like that. But my back pain had been there, sort of in my buttock area for about 3 weeks now.
Apart from diabetes, are you having any other comorbidities or illnesses?
Yes, doctor, I'm having high blood pressure also and cholesterol also. I'm taking medication for all of them.
I didn't get the neurological sensory distribution actually, Helika. Is there any sensory impairment in perineal area, especially saddle area?
No, saddle block, saddle anesthesia. Just a
Oh,
glove and stocking type anesthesia bilaterally.
okay.
On examination, what about the blood pressure and the pulses,
Yes,
peripheral
so
pulse?
yes, so very good. So blood pressure is actually normal, 120 by 80 like. So pulse rate is normal, 72, regular rhythm. And anything else that you asked, Dr. Nishi?
Peripheral pulses is
Yes, so peripheral pulses are weak. So left side femorals and down below are absent, whereas right side is normal.
can you name the drugs you are taking?
Yeah, I'm taking losartan for blood pressure and metformin for the my blood sugar control and atorvastatin for cholesterol. That's all actually.
Okay.
Are you a smoker, Mr. Helika, Dr. Helika?
No. No, I don't smoke and I don't use alcohol. No, that's it.
How about ABPI?
Okay, ABPI left side lower limb 0.07. Otherwise normal. Other limb is normal.
Have you had any rest pain when you're walking? Do you feel any calf pain?
Yes. Yes, doctor. Now that you tell me, yeah, very correct. I can't even walk 200 meters. I get this buttock pain, and I had to sort of stay in the same place for a while till it goes away. Maybe about 30 minutes. Within about 30 minutes, it goes away. Then only I can walk. Okay, I
Yes,
think
Mr. GR.
our time is up.
Mr. GR, what do you
Yes.
think? What is your opinion? Do you have any concern what it can be due to, like what it
Yes,
should be due to?
yes, Dr. Triam, you are very correct. I am worried that this is a stroke. Last time also I got this weakness, and now it's coming again. I don't know whether this is a stroke. That's what I'm worried about, actually.
Okay, so do you think that we can do things particularly for in this scenario?
Yes, Dr. Well, if you can, sort of do some MRI or something, I heard that you can pick up strokes with that, and so if you can sort me out, that would be great.
Okay, right, fine. We will take it in your and incorporate those things in our management plan.
Okay. So I think we have covered a lot of ground, and since the time is up, we'll move forward. So yeah, so I think you all asked almost all the relevant questions. So what are the differential diagnoses at this point that's going through your mind?
Peripheral vascular disease, PVD.
Okay, PVD. Okay. Anything else?
Root compression, cord compression.
Exactly. Yes. So any cervical or any cord compression causing compression, neurological impairment. Okay. Anything else?
Spinal artery occlusion, something like that.
Yeah. Okay. So again, in the spinal cord level, you can get either mechanical obstructions or even inflammatory changes like MS kind of things, and then vascular phenomena like what you said, spinal artery infarct.
Yes.
Okay. Anything else?
Stroke.
Transverse myelitis.
Okay, yes, very good. So again, intermediate condition in the spinal cord level, and of course in cerebral, you can if it's MS type, you can get it in the brain as well. Any more DDs?
Like stroke, right side.
Yes, exactly. So brain stem or either cerebral stroke is another DD.
DVT.
Sorry, sorry, I didn't get your answer.
Deep venous thrombosis.
Yeah, possible. Yes. So what is the unilateral presentation? DVT is also one of the DDs. Okay. Because you can get pain and again sense of fullness or heaviness of the limb with that. Yes. Okay, so let's move on.
Neurological disorders.
Sorry.
Functional neurological disorders.
Yeah. Okay. Yeah. Of course, we have to. That's also. I think we can consider in the DDs. So I think we have discussed several DDs. Let's move on and see what we found out. So yeah, so these are the things that I listed down. So it could be at any level. It could be at the level of the brain. It could be at the level of the spinal cord or the neurological and the nerves level, or even the myopathy or neuromuscular junction disorder is also a possibility. So specific questions to rule out brain such as PID, headache, some leg weakness, cerebral symptoms, which you usually miss. Sometimes we sort of focus more on basal weakness, but then you know that in posterior circulation strokes, you get cerebral symptoms more. And then diagram may be the only findings that you get in posterior circulation strokes. So that those are also very important symptoms that you have to elicit. And we discussed about the cord lesions and radicular lesions. I think history of trauma, pain, and bad bowel incontinence. And I forgot to mention, actually, can mention a sensory level are also indicative of a cord lesion. And inflammatory lesions such as MS, NMO, in this case, of course, a bit unlikely given the age. But again, in a young patient, you would consider the usual episodic nature of the progression of the disease are more towards that. In neuropathy, you can consider Guillain-Barré. There's a preceding history of acute gastroenteritis infection. But then again, the sensation, they say usually it's not affected, whereas the muscle power is that's what's more affected, and the reflexes, the generalized air reflex, and usually because what you have to consider in terms of neuropathy is paraneoplastic neuropathies. So anything that has some relationship to gastric carcinoma or lung carcinoma has to be ruled out. So loss of appetite, loss of weight, hemoptysis, chronic cough, water bowel habits has to be sorted out in the history. And myopathies are yeah, well uh, say they are petty, more than district, etc. Are more towards uh, etiology suggestive of myasthenia gravis. Hypokalemic periodic paralysis, of course, is again another channelopathy which can precipitate in the muscle level. I think you all may have heard of that. So it has a family history. Usually, it's an inherited condition of channelopathy, which causes transient paralytic episodes due to sometimes hypokalemia, that is low or high potassium levels. They usually have triggers such as infections, psychosocial, stressful situations, social situations can be sometimes the trigger. And for myopathy, again, you can consider hypothyroidism as well. So the general things that you would ask hypothyroidism has to be asked in history to think in that side. So moving on. Slides are not moving. Okay. So yeah, this is a summary of the history. So type 2 diabetes patient with peripheral neuropathy, and one thing that you all missed was the surgical history. So this patient has bilateral varicose veins, and he is wearing compression stockings, and these other things are called elicited, and the progress nature of the weakness. When you ask about the main weakness, ask specifically at what time did it start, and how is the progression? Is it static or is it progressive? Because there is, if it's a stroke, there is a window period that we can act upon. So that I just wanted to highlight. And then, yeah, all the other things I think you all point out, the pain with passive movements, paresthesia, and yeah, again, I would say, I would have said his lower limbs are, in my patient, the one I saw, he was wearing the stocks, one thing for the varicose veins, and again he said he wears them because if by accident he pricks the skin, he gets a wound very easily because his skin was so brittle. And actually, when we were trying to remove the stocking for examination, I picked him and he got a little wound. So, and like that, it's very, very brittle skin. And then the back pain, again, I wanted to highlight. So, even though the patient says back pain, we have to localize it, where exactly it is. So, actually, this back pain is a buttock pain, which is what we see in aortoiliac obstructions. So exactly, it's very important to ask the patient to point where it's hurting, rather than generally taking it as a back pain. Again, history of impotence all elicited for the breast pain and claudication, all that were elicited. Okay, so we move on. Examination. Yeah, so there was very important examination finding. Yeah, obviously, we didn't actually elicit all these details in the first go. We were actually more focused on the history of TIA and were worried that this may be a stroke. And everybody was thinking in that line initially. And what changed our approach was in the examination, we felt a slight coldness of the left lower limb compared to the right side. It's a very, very subtle slight coldness. And but the SR who was there was very much experienced, so she quickly identified that this to be very abnormal and continued with a full peripheral vascular examination, and then only we detected the absent pulses of the left side. So this is actually the conundrum that we faced because initially, if we had moved along the way of in the line of stroke, we would have definitely missed this case. And the things of the pain and paresthesia, the paresthesia, since he was having bilateral neuropathy anyway, he did not complain of that as a new complaint. So it was just the paralysis that he came up with. So very high chance of missing it because it was masked by the previous illnesses. Okay, examination findings are as below. And all in, as I mentioned, there was slight power reduction in the left side, and there was a pain at passive movements. Vascular examination, peripheral pulses are absent. CRFT is more than 3 seconds, and toe saturation was 70%. I have forgot to mention ABPI is also below 0.9, that is 0.7. Okay. One more differential diagnosis that I think we didn't discuss here is aortic dissection. So that's one lesson that I learned in that case scenario, and also I hope you will also gather, is that any patient with cardiovascular risk factors coming with neurological weakness and back pain, it's a must to think of aortic dissection as well, because sometimes it may not there may not be an like a very obvious aortic dissection where you have hemodynamic collapse with severe back pain. There can be intraluminal dissections which could lead to sort of symptoms with lesser intensity. So that's what I learned from the ETU people that day, is that any patient coming with back pain and limb weakness, apart from all the mechanical and musculoskeletal and cord compression things, also think of aortic dissection. Okay, so that's the pearl there. Right. So the complete diagnosis would be, yeah. So I think we got the answer as peripheral arterial disease. Would anyone like to refine that a bit to a complete diagnosis? Anyone? Hello?
What's your question? I could get it.
Yeah, what would be the complete diagnosis? Now we mentioned about the possibility of peripheral arterial disease, but yeah, in terms of a complete diagnosis, would you like to go a step further and give a a more specific diagnosis for this patient? Because peripheral arterial disease is a broad umbrella-like term.
Yes,
and
he's
it has,
not having rest pain, Heligram? Was he having rest
it
pain?
is,
No,
yes,
only
yes,
intermittent prolongation.
no, he is having rest pain as well.
Is it
Yeah.
acute limb ischemia?
Exactly, yes. So complete diagnosis would be acute limb ischemia in a patient with previous peripheral arterial disease and TIA and diabetic neuropathy. That was the diagnosis that I was expecting. So good. Okay, so what I'm going to talk about more today is about peripheral arterial disease. So as you all know, the peripheral arterial disease is a chronic disease of peripheral arterial obstruction or stenosis, resulting in impaired blood flow to either lower limbs or even upper limbs. So there are why do we have to talk about peripheral artery disease? Is it like we know that there's a condition like this, but usually we don't talk about it much in our clinical setting. But actually speaking, the prevalence of peripheral artery disease is so high that 20% of patients aged more than 60 years are said to be having peripheral arterial disease. So that is actually 1 in every 5 patients that you see is having some component of peripheral arterial disease. So what happens is, like, when patients with diabetes come complaining of lower limb pains, we just reflex, by reflex we attribute it to diabetic peripheral neuropathy and just say, okay, මේ ආච්චි diabetic තියනවානේ, so this is මේ වගේ nerves නරක් වෙලා. So that is a sort of by mistake, by reflex we used to attribute it to diabetic peripheral neuropathy or something like that. And when people come, elderly people coming complaining of back pain, we say, okay, so then I say I so that but then if you dig in more to the history, you will see something more like, some sinister things like blood clot claudication due to peripheral artery disease are there. So 20% of the population is actually 1 in every 5 patients is having this problem. So we had, as general physicians, I think we should be more aware of this condition and have to be more have to have a lower threshold to picking up this condition, especially in patients with diabetes. Okay, so moving on, peripheral artery disease has mainly 3 etiologies. So number one is atherosclerosis, that is fat deposition leading to stenosis of arteries. Then number 2, which is less common, is thrombosis. That is either on an already established atherosclerotic plaque, you could get a thrombosis, a new onset formation of a clot, or thromboembolism, that is shooting up of clots from elsewhere. But mind you, that usually causes acute limb ischemia directly, but rarely it can have partial obstruction and have peripheral artery disease as well. And again, thirdly, the third pathology is vasculitis. That also can lead to arterial obstruction. Out of the 3, anyway, atherosclerosis is the most commonest form of etiology. And talking about risk factors, males are more at risk of peripheral artery disease than females, and those with diabetes, smoking, obesity, and high blood pressure, etc., are at more risk due to obvious reasons. And talking about the peripheral artery disease presentation, so we discussed the thing about arterial claudication. So how do you define arterial claudication? Is it has to have 3 components. That is, it should be a cramp-like pain that starts after walking a specific distance. For example, the patient will say, මම අද 200ක් යනකොට මට කකුල රිදලා මට වාඩිලා ඉන්න වෙනවා. Like that, they come up with a specific distance usually. So there is a specificity in that figure. And then there will be the level of pain can be either in the calf or thigh or buttock, depending on the level of the obstruction. And mind you that the pain rapidly relieves following resting. Usually they say less than 10 minutes. So why we have to know this is because this is different from what we call neurogenic claudication. Neurogenic claudication is pain that is caused due to compression of nerve roots due to things like spinal canal stenosis. That pain is said to immediately start when you start moving, because when you start, it's a mechanical compression. So when you move about, as soon as you move about, the nerves get compressed and you immediately start feeling the pain, compared to arterial claudication, which you get after walking or exerting yourself for a specific amount of time. And then it does not relieve for a prolonged period. Usually it lasts more than 10 minutes. So that's again another feature that we can use to differentiate it from arterial claudication. And relieving with squatting and climbing posture. So, when you squat or when you climb, that is, so when you're climbing a flight of stairs, you tend to bend forwards, which sort of enlarges the spinal, so the vertebral canal, and relieves the compression temporarily. So that is why they get relieving of pain with squatting or climbing posture, which in both of them we sort of stoop forwards, causing our vertebra to sort of open up a bit. Okay, I hope it's clear up to now. So again, so the site of pain versus level of obstruction is also important. So if you're having an aortoiliac obstruction, usually you get pain and ischemia in the buttock, hip, and thigh region. As in our patient's case. And if you're having a femoral or branch occlusion, usually the pain is in the thigh or the calf. And so down below, like popliteal, you get pain in the calf, ankle, and especially the lower down tibial and peroneal artery obstructions lead to pain mostly felt in the foot. So second thing in the presentations of peripheral artery disease is rest pain, which our patient had. So again, rest pain also has 5 characteristics. It's a forefoot pain, that is, in the very front, the very anteriormost area of the foot pain, which has to be there for more than 2 weeks duration. So this duration is very, very important, because that then only we can classify it as a rest pain. Anything below 2 weeks, we have to think of acute situation, acute cause. So by definition, it has to be a pain that's lasting for more than 2 weeks duration, worsening with supine posture. That is, when you keep your legs on the bed flat, the blood flow to the legs becomes somewhat diminished and you get the pain. And when you put the legs down, when you keep them hanging out of the bed, the gravity supports some of the blood to come down back to the foot, so you get some sort of a relief of the pain when you keep your legs hanging down. That's why it's called rest pain. When you are resting flat on the bed, you are getting this pain. And again, it does not respond to simple analgesics. This is again a very important point. So you can use this to differentiate between diabetic neuropathy and peripheral artery disease rest pain, because giving Panadol or things like amitriptyline, like simple kind of analgesics, actually does not work on this pain. They need very high potent painkillers such as morphine or that kind of opioid type analgesics to relieve their pain. So if any patient not resolving with your usual gabapentin, amitriptyline, paracetamol, you can sort of think of peripheral artery disease again. So I think that's another pearl that we can take from here. Okay, so third presentation is tissue loss. So what we call tissue loss is either a chronic ulceration or a gangrene. Gangrene in the sense it could be dry gangrene or wet gangrene. Now, there is something called this funny syndrome, a nice to know thing called Lerici syndrome. I don't know whether you have heard of it. So it's a syndrome that occurs due to aortoiliac obstruction. So due to the aortoiliac obstruction, there is a triad of symptoms, which is buttock plane or the buttock claudication, absent femoral pulses, and impotence. So I think our patient is, a textbook case of Lerici syndrome, isn't it? So he had all these 3 symptoms. Apart from that, of course, unfortunately, he had the acute complication of it as well. So this is just a nice to know thing, because we can get misled, because all these are possible in diabetic neuropathy as well. You can get impotence, and you can get pain as well. So, but then again, you have to have a high index of suspicion and check the femoral pulses, etc., to exclude Lerici syndrome. Okay. So examination wise, the skin changes, the pallor, the coldness to touch, hairless, shiny skin, all point towards poorly perfused foot. So as I mentioned earlier, the turning point of this case was also the very slight coldness to the touch. So that's why the examination is said to be very important in any patient. And then the others, of course, we have discussed about the ulceration, swellings, and then swelling suggests the patient is sleeping in a chair to avoid rest pain, or rarely pain from deep infection. So sometimes patient will have low limb swelling, and which might suggest that the patient has been sitting on the chair, and that because of that has caused some sort of a dependent edema. So that is one of the giveaway signs we can expect. And again, absent foot impulses, they say if present, consider alternative diagnosis. Now, mind you, there is another version to this. I recently went through another CPD program of the same topic, and their vascular surgeon said that most of the patients, like I think 20 to 30%, there was a percentage, I can't remember exactly how much, had actually have impalpable dorsalis pedis pulses. But still, if you have one pulse, that is like posterior tibial pulses is patent, that could be enough to perfuse the whole limb. So if sometimes you may not feel the dorsalis pedis, but if you still have the posterior tibial palpable, it is then of course it's unlikely to be peripheral artery disease. Okay, and the ankle brachial pressure index below 0.9. The normal value is between 0.9 and 1. But mind you, this is not a diagnosis. This is not a test that we can use to exclude peripheral arterial disease, because in patients with diabetes or patients with CKD, they have this thing called arterial calcification. Their arteries are very, very hard due to deposition of calcium, which leads which leads to very high ABPI values, maybe even above 1. So having normal arterial ABPI values does not rule out peripheral arterial disease at all, but you can, if it is below 9, you can jolly well diagnose peripheral artery disease by its presence. Okay, I hope I'm clear up to now. Okay, so peripheral, the sequelae, what happens in peripheral artery disease? So it is said that 80% of the cases of peripheral arterial disease are stable. That is, even though they have peripheral arterial disease, 80% of the people will have the disease and die without any further complication at all. But about 20% of the patients can go into a worse stage of peripheral artery disease called chronic limb-threatening ischemia. This was previously known as chronic limb ischemia. They have recently changed the nomenclature to chronic limb-threatening ischemia in the recent guidelines. So 20% of the population will progress to that higher level of obstruction called chronic limb-threatening ischemia. We will discuss what it is later. And then those with chronic limb ischemia, that is, they are having chronic ischemic symptoms, can have acute on chronic symptoms. Suddenly, they are already stenosed arteries can get completely blocked, and that can give rise to acute limb ischemia. So that is how the two conditions differ. You can have acute on chronic phenomena like and get an acute limb ischemia. And apart from peripheral artery disease, people without peripheral artery disease also can get acute limb ischemia, but that will be due to other causes such as emboli, shooting of emboli in patients with aortic fibrillation, or due to trauma causing compartment syndrome, things like that. So acute limb ischemia can come either from as a complication of peripheral artery disease or on its own due to other phenomena causing arterial obstruction, acutely obstructing arteries. Okay, right. So chronic limb-threatening ischemia or critical limb ischemia, as we used to know it previously, has the following definition. The symptoms have to be more than 2 weeks duration with objective evidence of significant peripheral artery disease. That is either ABPI less than 0.9, or there is something called toe capillary pressure, which should be below 60 millimeters mercury. So this is nothing fancy. Toe capillary pressure is actually a very tiny blood pressure cuff which fits into your toe. So you measure your pressure in the toe, and if you get it below 60, you are said to be positive for peripheral artery. Objective evidence of peripheral artery disease is said to be positive. So you have to have symptoms for 2 weeks duration and objective evidence as above, and either rest pain or tissue loss such as gangrene or ulcer. So you can either have only rest pain, or without rest pain you can have a tissue loss. So any one of those, if it's positive, you can categorize it as chronic limb-threatening ischemia. So our patient, of course, did not have any gangrene or ulcer, but he did have breast pain. So we can put him into the category of chronic limb-threatening ischemia. Okay. Okay. So moving on, if we discuss about the other complication, possible complication of peripheral artery disease, that is the acute limb ischemia, is due to acute complete obstruction of blood flow to the limb. And it carries a significant mortality and morbidity if especially the duration exceeds more than 6 hours. So it's considered to be a surgical emergency. Whenever you pick up a patient with acute limb ischemia, you have to do an urgent surgical referral for vascular intervention. So as compared to chronic limb ischemia, the causes of acute limb ischemia are acute thrombotic occlusion of pre-existing stenotic segment, that is about 60%, and emboli from elsewhere 30%, and as I mentioned, trauma causing compartment syndrome or vessel damage, again a minute percentage. And there are the classical signs and symptoms of acute limb ischemia, that is what we know is as the 6 P's. The 6 P's is in the order of presence, that is in the order of appearance. The first one is pain on passive movement. It is said to be the earliest and the most sensitive physical finding. So when the patient's limb is kept idle and that at rest and you move the limb, the patient will feel pain. So that is pain on passive movements. It's very important to figure that out. And fallow pulselessness are the other 3 early features of acute limb ischemia. You can also have paresthesia, perishing cold, and paralysis, which out of which even paralysis is somewhat late presentation, because due to the obstruction and blood reduction in blood flow to the muscles and nerve tissues for a long time, you can get paralysis and paralysis as well. Right. Moving on, now we have something called a severity classification in peripheral artery disease. So, as in any disease, we can, there are sort of 2 schools of thought in classifying peripheral artery disease. So, one that we use more commonly is the Fontaine classification, whereas again, very much similar classification called the Rutherford classification is also there. But I think we can stick to Fontaine classification because it's very easy to use and very much clinically oriented. So yeah, so stage 1 is you have objective evidence of peripheral artery disease, but the patient is asymptomatic. 2 is mild claudication. 2B is moderate to severe claudication. So the differentiation here is 200 meters. If the patient is having claudication within 200 meters of walking, you call it moderate to severe claudication. And stage 3 is presence of ischemic rest pain. And stage 4 is presence of ulceration or gangrene. So as you can see, the stage 3 and 4 fall into the category of critical limb ischemia or chronic limb threatening ischemia, which we previously discussed. Okay, I hope it's clear up to now. Right. So moving on, when you have a patient diagnosed or suspected with peripheral artery disease, there are certain investigations that we can do. So at our level, that is at GP level, of course, it's very much limited. We can, of course, do the full, the basic workup like full blood count, urea electrolytes, creatinines, and ECG and all, and again measure the ABPI. So imaging findings, of course, you can do duplex ultrasound to determine the site of the disease, and then CT, MR, angiogram, and digital subtracting angiogram. But all those are usually done in specialist care settings. So another thing, important point that I would like to highlight is, do you want to ultrasound scan or Doppler ultrasound scans in all patients with peripheral artery disease or suspected peripheral artery disease? Anyone? Anyone?
As it is less expensive and less invasive, I think it is important.
Yes, okay, good. Any other thoughts?
Only if you are intervening surgically to know the exact height and the extent of the
Correct.
block.
Thank you. Yes, correct. So that's the thing. So even I was also before I was reading up on this, I was also in thought that any patient with peripheral artery disease, we have to do the ultrasound and we have to diagnose by ultrasound before referring. But actually, it is not the case. It seems with history and our examination itself, we can diagnose it. And why we need to do ultrasound scan or any other imaging modality is to find out the level of obstruction to intervene. So that is actually that falls to Fontaine 2B and above. That is Fontaine 2B. Sorry, go back and show you. So asymptomatic disease and mild claudication patients, that is their disability or the claudication is not disabling to their activities, can be managed conservatively and medically, and they do not need surgical intervention, and they do not need to be imaged. But of course, patients above 2B, Fontaine 2B, have moderate to severe claudication, and they have impairing or disabling claudication. So they need surgical intervention. For that, they have to undergo Doppler Doppler studies, arterial Dopplers. So that is the thing that I think is somewhat new for us. So if I'm intervening, you have to of course go ahead with ultrasound Doppler. And second indication would be something like an acute limb ischemia, because most of us we have the facility available at the bedside now, especially in the ETU. At that point also we had a ultrasound scan, and at that point they did the ultrasound Doppler and found the lesions. So that is also another indication. Thirdly would be a diagnostic uncertainty. So if you are not very sure that this is peripheral artery disease, of course, yes, you have to do a Doppler. But again, I would like to say, so their consensus is that if it's clear-cut peripheral artery disease, which is non-disabling, that is below Fontaine 2B, you don't actually need to send for imaging. That's the lesson here. Okay, so management. So management again, we divide into the same classification: Fontaine 2B and above and below. So anything below 2B is non-disabling arterial claudication that we can manage at GP level. What we do is what is called supervised graded claudication exercise. We ask the patient to walk for at least 45 minutes a time for at least 2 hours per week for a period of 3 months. And we have to instruct the patient to walk to the maximal point of pain. So not as he should not stop as soon as he gets the pain, but try to walk a bit more further and get to the maximal point of pain to make it more successful. So what they say is the supervised graded claudication exercise improves the claudication distance very significantly in most patients, probably due to neovascularization. So there are collateral formations are triggered by this graded exercise, which causes them to have improved claudication distances. So that is what is number one in our management. So second one is use of aspirins and statins. As per any arterial pathology, they are indicated in all patients, and we have to start them on patients with peripheral disease with aspirins and statins. Thirdly, there are two drugs that I have mentioned here. These are, of course, like grade 2, like evidence-based drugs, not 100% established. They are said to reduce claudication, improve claudication distance by way of means of vasodilation. So here silastazole is the one that is available in Sri Lanka right now at a dose of 100 milligram BD for 3 months. It's a phosphodiesterase inhibitor, which causes vasodilation and sort of an improvement in coagulation distance is seen with that. Naftidofuryl is another drug that's mostly seen in Western countries. As I know, it's not available here. It is a 5-HT receptor antagonist, and again, it has mechanism similar to elastazole, causing arterial vasodilatation. Okay, so then fourth one is footwear and foot care. So most of these patients with peripheral artery disease are patients with diabetes. So they will have the full package of foot problems that comes with diabetes, apart from the peripheral artery disease. That is, hematomes and the destruction of the flat feet. All those things are there, and they are more prone to get complications of diabetic foot disease anyway. So we have to sort of advise on offloading shoe, and the usual diabetic foot advice has to be again applied here. So foot care again is the same. Another important thing is screening for modifiable risk factors. So when you have a lesion or an obstruction or from atherosclerosis at one point, that means you might as well have obstructions elsewhere as well. If you have a block in your femoral artery, there is very high chance you have more blocks in your carotids and coronary arteries as well. So it is very important to screen them at this point for possible coronary artery disease and cerebrovascular disease. And again, CKD is also a possibility because of long-standing diabetes and again renal artery stenosis. And risk factors, especially if the patient is if the patient is a smoker, or if he's having uncontrolled diabetes, or if he's having uncontrolled cholesterol, it's very important to control them to prevent the progression of the peripheral arterial disease. So just by doing these things, we just can't leave the patient alone. We have to follow up the patient, maybe every 3 months, to see how the patient is improving. If there is no improvement at 3 months, then again it is an indication for us to refer the patient for specialist care. We have to regularly follow up the patient to see how it goes. Okay, so this is some excerpt I have taken on supervised exercises. So they have said that these exercises work more on patients with content 2A or less, whereas in critical limb ischemia, the graded exercise, the supervised exercise does not actually work. So they have to go for intervention. Okay. Right. So next big question is, when do we have to refer these patients to a vascular specialist? So the ones that are having non-disabling arterial claudication, we can manage, but those who are having disabling arterial claudications or the following, that is acute limb ischemia, critical limb ischemia, or severe symptoms and or uncertain diagnosis, or not improved after exercise training for 3 months, we have to refer for specialist vascular care. Okay. So specialist management, I will not dig deep into it. We just have to know what are the options available to educate the patient about it. So there are things like percutaneous transluminal angioplasty and stenting and bypass surgery. So there are various indications for doing one or the other. For example, where the segment is located and how much long the segment is, and what are the comorbidities the patient has, decides what procedure this patient can undergo. So, since it's not very relevant for us, I will skip that. What is relevant for us is the wound care. So yes, at specialist management, of course, they will do salvage wound toilets. But here, what is very important is that we do not treat the peripheral arterial disease wounds as any other, diabetic infected wound. What happens is, now we see an area of sort of unhealthy tissue, and if we start dissecting it, there will be no end. You know, there will be no, because anyway the health of the tissues are very poor. However much you go on cutting and cutting, there will be not much of a blood supply, and you will ultimately end up cutting so high that the foot is unusable. So that's why they say in primary care, when we are doing wound toilets, before keeping the scalpel, check the pulse and see. If there is poor pulse, think twice, because our wound toilet is actually going to be a detriment to the patient than a help. This is not the case in a patient with very good perfusion of the legs and having a diabetic wound. Of course, yes, we have to do salvation therapy and remove as much as possible of dead tissue as possible to get rid of the infection. But if you try to do that in a limb that is already ischemic, it's going to sort of end up at a level of amputation. So that's a very golden key point that you have to keep in mind when doing wound toilets. I hope I'm clear. Okay, so now we have discussed about the acute chronic management. So when it comes to acute limb ischemia, again there is it's an emergency management. Rutherford 1 to 2A can be medically managed with heparin and low molecular weight heparin, and Rutherford 2B and above, that is symptomatic disabling disease, you have to go for surgical interventions such as embolectomy via Fogarty catheters or radiological guided thrombolysis, etc., etc. Anyway, since this is of more of a specialist area, I will not dig deep into it. You can read about it especially if interested. Okay, so coming to the end now. So take-home messages I would like to reiterate. Always suspect cerebral arterial disease in patients with diabetes, and don't forget to check peripheral pulses, things like warmth, etc., in seemingly neurological presentations. Because we almost did that. We are almost because of the heavy burden and all in the ETU, we almost missed checking the pulses. But luckily, since we got the clue from the slide coldness, we proceeded along that way and were able to diagnose the condition properly. So any neurological presentation, always assess for the vascular component as well. And make it a habit to differentiate between diabetic neuropathy and rest pain due to chronic limb ischemia. And again, keep in mind, all back pains may not be musculoskeletal in origin. So very important, I think, eye opener. And be familiar with the management of non-disabling peripheral artery disease, and know when to image a patient and when to refer. Especially eyes. I just I couldn't add one thing there. So what they say is that rather than, if we want to image a patient, now if we find a patient who is Fontaine 2B and above, the time we take to get the patient to do a arterial Doppler and then to go to a vascular surgeon is again going to lead to a delay. So what they actually suggest is they refer directly to the vascular surgeon and they will perform the arterial Doppler by themselves. So that will save a lot of time and a lot of tissue. So that is what that is the message given by the vascular surgeon. If you, rather than wasting time doing Dopplers separately and referring, you can actually directly refer the patients to a vascular unit, and they will do the necessary imaging and management thereon. Yeah, other important thing is avoiding compression stockings. Now, I think you may recall that this patient was again on compression stockings for varicose veins. So it's detrimental to it's even though by reflex we sort of advise compression stockings for mild varicose disease, we have to always check the pulses before administering them, because if there is if the patient is having venous disease as well as arterial disease, and if you go on and apply a compression bandage, this arterial component is going to get compromised and he's going to end up in critical limb ischemia. So golden point is before prescribing venous compressions, you have to check the pulses and make sure there is no underlying peripheral arterial disease. And lastly, over-enthusiastic wound toilets in patients with peripheral artery disease should be avoided and it should be left for the specialist as much as possible. Okay, so yeah, feedback on our patient. So he successfully he was undertaken by the vascular team immediately, and he underwent aorta bypass grafting and was said to have a successful recovery. And further, his cardiological neurological evaluation was planned, but once the acute condition was settled. So that's it. These are my references. I used the up-to-date. There were 2 articles on peripheral disease and chronic limb ischemia and the GP handbook. Very important. There is the CPD update on peripheral disease by one doctor, Buddhimajaya Kramer, a consultant vascular and transplant surgeon. It's a very recent CPD program. It's available on YouTube. If you have time, just go through it. He gives a very good account of recent management updates in the that video. Okay, any questions?
Yes, Kelika. Again, going retrospectively back to the presentation of
Yes.
Mr. MR, he said, Doctor, all of a sudden I couldn't move the limb. Is it due to the pain or weakness? Couldn't be differentiated at the presentation.
Correct. So it's actually both. So he had a paralysis component as well. And
Paralysis
pain and
component will come, as you said, it's in the chronic stage only, you know?
it's a late manifestation. When you have
Yes.
acute ischemia for more than 6 hours, they say, you get symptoms of paralysis. So this patient had paralysis for 3 hours. That means he may have been developing the impairment even before that.
Oh, right. I thought Mr. MR was purposely deviated us.
No, actually, it's a real case. Okay, any other questions?
Correct. Right.
Kelika, regarding referral of this patient, as most GPs don't have facilities to check ABPI.
Correct.
We can check the history and we can check the pulse. Is that enough to keep the patient with us?
In the sense, without referring?
Without referring to the surgeon.
Yeah, usually now the thing is the checking ABPI, what we need is the usual blood pressure cuff and arterial Doppler. In some places, of course, it's a handheld Doppler, it's available. And if you have that facility, yes, you can diagnose it on your own and manage. But if you do not have the facility, you don't have an option but to refer. That is true.
Yeah.
Correct.
Okay.
Anything else? I actually have a small video on how to check ABPI, but I think the time is not
in that case, can we order duplex scan and decide on when refer? Can we do that?
Yeah. So then it falls under the category of diagnostic uncertainty. Then of course, yes, it's an indication. Again, what my personal opinion would be that if we still do a vascular referral without doing the Doppler study, they themselves would find it very easy to do the Doppler on their own. The reason is when you give a date, when you ask for a Doppler date in a government setting, you get dates, maybe 1 or 2 months down the line. So by that time, you do not know what will happen to the patient. But whereas in vascular units, then and there they do the Doppler, and there's a lot of time saving if you directly refer.
Yes, thank you.
Okay. Any more questions? Okay, I think that's
Hello? Yeah.
Yes.
Yeah, I have a question. You mentioned
Okay.
that 50% of peripheral vascular disease is stable and only
Yes.
20% progresses to acute limb ischemia.
Chronic.
Did you find
Yeah.
come across like a tool in the literature that where you can predict which way it's going to go at the primary care level, which we can use? Because most of the patients they are lost to follow up. They don't
Correct.
usually come again and again. They just do what they want, and then come like what happened. That's one question. Second one is who prescribed the stockings? And
Yeah.
before, did they look at the ABPI before prescribing, and was it like a 4-layer one for the
No, it was just
varicose, or did they do a proper thing? Or
probably
yeah,
not. Probably not. It must have
and
been
did
prescribed.
that contribute like iatrogenic to push him into more ischemia?
Yes, very much possible.
Yeah.
Very much possible. And I don't think he was properly evaluated before
Third question
prescribing of
is
these stockings.
how now this patient is a diabetic and also a TIA. How the PVC was missed all the way up to acute limb ischemia.
In the femoral pulsation.
No, you said he's diabetic, isn't it?
Yes.
Yeah, he would have had it for a few years, and also recent TIA. So, I mean, didn't he have any symptom bad enough to tell about it to a doctor until it progressed to acute limb ischemia?
Yes,
It's a
that's the
bit
thing. So that
difficult to understand.
exactly. So that is why because this patient was having peripheral neuropathy. So most probably he and the other doctors were attributing all these symptoms for diabetic peripheral neuropathy. That's what I had in mind. So that whenever he was complaining of pain or even the paresthesia component, he would always think, this is the neuropathic pain that is coming, which usually is the case. So his symptoms, the 6 Ps, or even the symptoms of critical limb ischemia, could say were masked by a dual pathology, that is the diabetic peripheral neuropathy. That's one reason why I actually wanted to name this as a masquerading limb weakness, because one condition actually masked the other and sort of led to a delayed diagnosis. And coming back to your first question, whether there is a tool to prognosticate the sort of provision of peripheral heart disease, I actually have not come across a specific tool of that nature. I will look into it. But there is this tool called the Wi-Fi scope, which is used by vascular specialists to evaluate patients who are having wounds with peripheral arterial disease. Any wound, they usually assess the Wi-Fi score. So Wi-Fi stands for wound, W wound, I for ischemia, and phi means infection. So if there is when there is a wound, the how the nature of the wound, and secondly whether the wound is a ischemic wound is taken into consideration, and they give a particular point to it, and then the level of ischemia, the infection. So calculating the Wi-Fi score, they can prognosticate wounds and say out of how much of these are going to end up in amputation. So that tool is available as my knowledge. But for peripheral artery per se, of course, I do not know. I will go a bit deep into it and have a look at it. Thank you for the question.
Thank you. And what about the stocking?
Yeah, it's just the general compression stocking that is over the counter available, not the layer bandage. Usually that's available in the branded ones, like elastic type of a stocking. Hello.
Is it the graded stocking? It's class 2 grade stocking.
it is a graded stocking, but not the compression bandage that we manually put. Like the layer bandage, it's just a single layer commercially available graded stocking.
Right, thank you.
Okay.
Thank you.
Okay, thanks. Any other question? Okay, since I think we have come to the end of these questions, I would like to thank Dr. Madam Lalata Madam for guiding me to prepare this presentation at a very short notice. And thank you for all who are participating and actively discussing and listening. And I hope I was able to give some useful tips for your practice, at least one or two. Thank you.
Hello. Can you all hear?
Yes, madam.
Yes, madam.
Yes.
Yeah, okay, fine. Now I was listening and I was listening the discussion and okay, this is a sort of a different way of presenting because you wanted to be like a patient and then they ask questions and ultimately the real discussion started with the like it's very this the way you started is also good and the way you did the presentation like sort of a all the explanations are good but I'm asking if it is a real patient the way you asked questions is I don't think this is the way because I was like thinking actually you didn't like do this type of a sort of a like open-ended questions all were closed-ended like do you have this do you have that so all like from the beginning and till the end all the like people they ask this closed-ended question this should not way the like do I mean the way you should ask from the patient even at the exam or this just need I mean like day-to-day practice because like we have already mentioned and already told you I've already taught you all it should be closed-ended so she told okay I have this type of a problem and you can ask some questions so then instead ask like do you have these do you have that you know how you have to start the closed open-ended question nobody asks that if you ask could you please start from the beginning what had happened to you tell me like sort of explain what type of pain you had or something like that what are the any sort of now so then the patient cannot stop giving one answer or the person has to they have to like explain what according to the way you ask the question it is the only because I was thinking this should not be the way that we have to ask even at the exam so that is a problem okay fine anyway because he asked you to ask questions then you ask this way but it should not be the way you have to do okay and then regarding the sort of this presentation of the real story now the peripheral vascular disease or the acute living ischemia okay fine but like it is good that if you can explain it with some sort of a pauses to make the listener to understand. So like it's like sort of a you give all the information a little bit of a in a sort of unplanned way. So it should be the way the brain can understand step by step. This is what, and then you have to say accordingly. This should be the way, like sort of a little bit of a explanation, not like explaining the history and give the sort of the facts. So okay, fine, but anyway, it's a kind of a good presentation and good start for the others as well. But therefore, next time, if you want to do this type of I mean, the actual patient conversation, the question you should ask the way actually you do at the exam. So it's anyway, it's that you did a good job. Anyway, I think others also nicely contributed for that. Their concerns, their sort of differentials. And okay, fine. It's of course that not a single person like tried this type of the topic earlier. Anyway, it's a good one. Thank you very much.
Thank you very much madam, for all the guidance and advice, madam.
Okay then.